All right, everyone. Thank you so much for joining us tonight. As Lauren said, my name is Kathryn Lister, and I am a physical therapist at Physiotherapy Associates here in DC. I've had the pleasure of working with clients with EDS, dysautonomia, chronic fatigue syndrome, and POTS. And it is an amazing and educationally filled job. And I'm excited to share some of what I've learned with all of you guys. And just to kind of hopefully continue the conversation about what all we know and what all there still is left to learn. As a preface, as we start, please, I want to know this is really here to be a educational webinar. There's a lot of information out there, but this is not meant to be a very cookbook list of treatments for people. It is a starting point. As you guys all know, your presentation, your symptoms, your life challenges are all very, very individual. And as a result, your treatment should be as well. So as we go through, please feel free to ask me any questions that you have. There'll be a few points in the presentation where we can stop, and I will address some of the questions throughout the presentation, and then of course the end we'll spend the majority of hopefully the last 45 minutes just kind of answering some of those questions. All right, so without further ado, let's go ahead and get started. So the title of this presentation is Intelligent Exercise. How can you take control with EDS? Let me go ahead and see if I can click through. All right, perfect. So let me close this. Oh, give me 1 second. Sorry, guys. Trying to get this control panel out of my way. All right, perfect. So according to APTA, which is the governing body of physical therapy, there are a few things that we are beholden to do. This is kind of our motto, and this is where we come from as physical therapists. Our job is to diagnose and manage movement dysfunction and enhance physical and functional abilities. Is to restore, maintain, and promote not only optimal physical function, but optimal wellness and fitness and optimal quality of life as it relates to movement and health. And lastly, we are to prevent the onset, symptoms, and progression of impairments, functional limitations, and disabilities that may result from diseases, disorders, and conditions. So to break that down into something that makes a little bit more sense, I'm just going to kind of pull out those action words, all right? The first is really to manage. Our job is to manage, and the managing that we are doing is that of movement dysfunction. We are supposed to enhance functional abilities, restore, maintain, promote optimal function, optimal wellness, and optimal quality of life. And then, of course, lastly, we want to prevent progression, functional limitations, and disabilities. To take that one step further, I'm going to discuss this in the realms of Ehlers-Danlos and kind of just plug in some of the things that clients with Ehlers-Danlos are going to be suffering with and challenged with the most. So underneath the idea of managing movement dysfunction, so many times people with Ehlers-Danlos you've got hypermobility, pain, decrease in impaired movement pattern. And those are the things that underneath that category of managing movement dysfunction, this is where we're really going to focus. In order to enhance functional abilities, as you guys all know, there are definite challenges that come with daily social and recreational activities. So really just kind of participating in the world around you. And one of the goals that we're going to talk about today is how we can enhance those functional abilities in order to participate with those more effectively. Third, we want to restore, maintain, and promote optimal function, wellness, and quality of life. As I'm sure you guys have dealt with, but also the research has shown there's low quality of life scores in physical and psychosocial realms when we're working with people who are working with and fighting with Ehlers-Danlos. And so we want to talk a little bit about how physical therapy and exercise can help to improve those quality of life scores. And then lastly, we want to prevent the progression of functional limitations and disabilities. Now, one of the biggest challenges that people deal with when it comes to Ehlers-Danlos syndrome is that tendency to spiral. One thing goes wrong, and then so many other things just kind of start falling into place, and you end up with this spiral, this bit of a tornado down into a negative symptom presentation. This is one of the last things that we're going to talk about as far as how exercise and how physical therapy can help to prevent that, to stop that spiral kind of in its tracks and put you guys back at the helm of being in control of your bodies. So to pick out the very first one, we're going to talk about Ehlers-Danlos and how to manage the movement dysfunction. So that movement dysfunction is defined as hypermobility, pain, impaired, and decreased movement patterns. Now, Ehlers-Danlos is a connective tissue dysfunction, and we're going to get a little bit into what connective tissue is for those of you who are not quite familiar with it. But that connective tissue dysfunction causes hypermobility. Hypermobility can then cause pain. Pain can then cause impaired movement patterns, and those impaired movement patterns then result in decreased activity level, which overall is not where we want to be when we're fighting and dealing with Ehlers-Danlos. I'm sure you guys recognize this amazing picture at the bottom. This is our Beighton scale. This is the rudimentary and very rough way of kind of looking into mobility and seeing where you fall. Being able to bring your pinky back to 90 degrees, being able to bring your thumb to your forearm, straightening out your elbows so that there's at least 10 degrees of what we call hyperextension, so bending backwards the wrong way. The same thing in that leg, even though the leg doesn't really look like it's hyperextended. But then lastly, on picture number 5 right here, where you're going to have the hands flat on the floor. And again, with the hypermobility, those knees should not be bent. But we'll give the artist a little bit of a break on this one. All right, so diving right into connective tissue. So the purpose of connective tissue is really to support, connect, or separate different types of tissues and organs in the body. Now, in the body, there are 4 basic types of tissue. You have nervous tissue, you have muscular tissue, you have epithelial tissue, and then you have connective tissue. So there's really 4 major types of tissue, and of those 4, connective tissue is by far the most abundant. We find connective tissue in the blood, you find it in the vessels, you find it in here, what we're talking about with the ligaments and your tendons. You find it in bone. Connective tissue is kind of everywhere, and it plays a really big role in holding our body together. Now, as we're looking a little bit more towards this, ligaments, more specifically in that musculoskeletal system, which are, of course, ligaments are made out of connective tissue. Ligaments, their job is to connect bone to bone. So here, if you can kind of follow my cursor, we're looking at the medial collateral ligament, or in this picture it's called a tibial collateral ligament. You've got your posterior cruciate ligament, you have your ACL, your anterior cruciate ligament, which we all hear about pretty much every Sunday now during football games, and you have your fibular collateral ligament, which is also called your lateral collateral ligament. All of these are made strictly out of connective tissue, and so their job is to help stabilize this joint. They're really trying to keep this together. And so this is, as I mentioned before, this is a knee. So this is your femur and this is your tibia, and these ligaments are doing their job to help keep this knee stable. Now, a tendon, also a job of stability, their job is to connect a muscle to a bone. So here's your quad. You only see 3 of the 4 muscles, but your quad, and then you have a tendon that then transitions and connects that tendon to bone. All right, and so you can kind of see that here with your rectus and your lateralis and your vastus medialis. But again, the purpose of the tendon is that transition unit to really help that and adhere that muscle to that bone. All right. So connective tissue, trying to get a little bit of a better idea of what defines healthy connective tissue and what defines your hypermobile connective tissue. So in a system where the connective tissue is really hypermobile, it's going to be quite stretchy. There's going to be a lot of stretch to it, a lot of play to it. In a typical system, in a system where the tissue is not super mobile, that connective tissue should be pretty taut. It should be similar to like a leather strap that's been wrapped around something. However, when there's a lot of tensile quality, that leather strap that is meant to bind things very very tightly is now a little bit more like a rubber band, okay? Now, that becomes problematic when you're thinking and talking about joints, all right? So if, I'm going to step back a little bit. So if these ligaments right here, if they're no longer like that tight leather and are more like rubber bands, then there's going to be a lot more extensibility in that joint. Same thing, if you have a lot more rubber band qualities to this tendon than you would more like a leather component, then that is going to be a lot more extensible and a lot more stretchy. With tendons specifically, all right, in a healthy connective tissue, the muscle is more like a, very stretchy, it's like a rubber band, and the tendon, let's say, is like a metal coil, okay? That's kind of what we're looking at here, is where if you have the tendon that is like a metal coil and the muscle is like a rubber band, that tendon is going to stay pretty taut while that muscle stretches, because that muscle is contractile tissue. However, when you have more of a hypermobile type of connective tissue, then it's going to be a little bit different. Now you have the tendon acting more as a rubber band and the muscle acting more like the metal coil. This is one of the reasons why so many people who have connective tissue disorders feel like they're really, really tight. Because in actuality, those muscles, the muscle belly where those sensors are, the muscle belly is really tight. But unfortunately, the tendon is very stretchy. And so we'll talk a little bit more about this later, but when that tendon is really stretchy, when you actually go in and try and stretch your muscles, often what you're stretching is the tendon, because anytime you have a coil attached to a rubber band and you go and stretch, it's going to be that rubber band that gives way and not the metal coil. So that is kind of just a pretty simple breakdown of how that connective tissue will work and can work. And we'll dive into that a little bit more. So the whole reason why we talk about connective tissue in musculoskeletal system is really because it plays a big role in the stability of a joint. Okay? Now, the stability of a joint is defined by three different things. It's defined by bony approximation, it's defined by its ligaments, and it's defined by its muscle. Okay? So a bony approximation is basically how much connection there is between one bone and the other. So I brought out these two examples. As you can see, this is the elbow. There is a large connection there between the ulna and the humerus. Okay, there's a lot of contact, and so this is what you would call a hinge joint. And with that being a lot of contact, it's a pretty stable joint. Now the shoulders, on the other hand, you can see this is the humerus and this is the scapula. There is not very much connection there as far as a bony approximation between that ball and that socket. It's more like a golf ball sitting on a tee. So as a result, the shoulder by nature is going to have a lot more range of motion. Okay, even in a non-hypermobile individual, the shoulder is going to have about 180 degrees of motion in all planes. You can bring it forward, you can bring it to the side, you can do big circles, you can pull like a Michael Phelps where he's almost swinging his arms all the way around. Whereas the elbow, you kind of can bend and straighten it, and that's about the extent of the motion. And so there's your difference between that bony approximation of the shoulder blade and the elbow. Now, the second level of stability that we talked about is the ligament, all right? So kind of heading back to this picture of the ligament, all right? So here's your bony approximation of the knee, and then here is the ligamentous connection, all right? And those ligaments do a very important job of keeping the joint stable and not allowing any movement. And then your third level is going to be that muscle, okay? The third and most superficial level of stability is going to be your muscle. And that is what we're going to dive into next, because your muscle is really the key for us. The muscle is really where we want to go and what we're going to hone all of our attention onto. So just as I was talking about with the bony alignment, here's a hip, okay? The bony alignment, there's not much that we're going to be able to do to fix that bony alignment. Definitely not in PT. The bony alignment is what it is. You have more bony alignment in your hip than you do in your shoulder, and that's just kind of the end of it. Even though there is connective tissue and bone, oftentimes hypermobility doesn't necessarily affect the way that those joints line up. So with that, it's not super affected. We're going to leave it be. Okay, dropping down here though with the ligaments. Ligaments, of course, are dramatically affected. The ligaments become very, very stretchy and very, very tensile. However, even though they're very dramatically affected, we can't really do anything about that in physical therapy. We can't change the tensile quality of that ligament because it is all connective tissue. And that is something that other areas of science are kind of working on as far as what we can do to tighten up those ligaments, or if it's even possible to do. So that as well, we're going to kind of leave that alone. Now, with the last one that we're going to kind of swing back through is going to be the muscles. All right, so the muscles, like I said, this is where we're really going to hone in on what we can accomplish and the changes that we can make through exercise. Now, as we mentioned before, the muscle is, you have muscle belly, so this is the gastroc. You have a muscle belly here, and then you have this tendinous sheath that comes down and connects to the bone. This tendinous sheath is often too stretchy, and this gets really tight, and so the mechanics are flipped from what is typical. But the muscle is really where we can affect and make the most change. So how do we make the most change with increasing muscles, and why is it that we can do that? All right, so in our body, we have two major types of muscles. We have our deep stabilizers, and we call them deep stabilizers because they're usually the first level of defense. They're the first level of muscle in our body. And then we have the big global movers, and those are the big ones. Those are the ones that we kind of see all the time and that we think about all the time when we think about muscles. Now, your deep stabilizers, this picture on the right is a picture of your multifidi. All right, so here's the spine. And this is one segment. This is the spinous process of one segment, the part of your back that kind of pokes out. And this is 1, 2, 3, 4. All right. Now you can tell this is one stabilizing muscle. This is one stabilizing muscle. And then you have another one that's connecting from this process to this one. You have one that connects from this process up to here. So these are tiny, tiny muscles that aren't really going far at all. But that is because their job is to keep this joint from moving too far on this one. All right? You're keeping this joint stable. You're preventing one bone from gliding forward and gliding backwards. This is our active control of the joint mobility. Okay? And so at its very, very deepest level, these deep stabilizers really can help to make a difference and to play the role of a ligament that may not be functioning as well as it should. Okay. The other key thing about these stabilizers is that they are on all the time. Okay. A stabilizer is more like an endurance runner. Okay. So an endurance runner, they're not, well, I as an endurance runner was never super fast, and most of them are not super fast. And so an endurance runner is, they're moving, and they're always moving. But if you put an endurance runner next to a sprinter, then it doesn't really look like much is happening. And that's really what should be happening with these stabilizers. They're firing. They should be firing, let's put it that way, all the time. Anytime you are standing up, anytime you are moving against gravity, anytime you are scratching your head, or anytime you are picking up your pen, those stabilizers are firing in order to counterbalance the movement and keep you in an upright position. They're your number one defenders against gravity, okay? And so they should be working all the time, but because they're working all the time, they're only able to, fire at about 20-25% max of their effort. And this is going to become important later on when we start talking about what exercises to do and how to do the exercises in order to activate these stabilizers. But just remember, endurance, slow activation, they're always working, but not really going crazy. All right, and so that is your deep stabilizers. Another example of the stabilizers would be your rotator cuff, and this is one you guys may have heard about. There are 4 muscles in your shoulder, all right, that help to stabilize that shoulder. And if you remember that picture of the shoulder, we're really looking at a lot of mobility there because of the bony alignment. You can kind of see right here. So that is going to be the first. And then the other one that I mentioned in here are going to be your deep hip stabilizers. And we'll talk about those, and I'll show you some pictures of those in a little bit. Now, your movers are also important. I don't mean to undermine the movers and what they do. Your movers are like your bathing suit weather muscles, the ones that everybody thinks about. It's your pecs and your abs and all these other things. And really, those muscles, they're important. They're important because they help us to pick things up. They help us to stand up. They help us to walk. They're the ones that allow us to move. But kind of linking back to the stabilizers, in order for something to move, it needs something stable to move against. Okay, so it's kind of like the difference between trying to balance on one foot when you're standing on solid ground versus balancing on one foot when you are standing on a raft in the middle of the ocean. Okay, if there's nothing stable underneath those movers, then those movers are not going to be super happy. Now, just to spend a little bit more time with this beautiful picture and this beautiful slide, the challenge that we run into is that our stabilizers are a little bit fickle. When they get angry, when they get overworked, or when they're not worked at all, they just turn off. They go on vacation. They're done. They're not putting in the effort. If they're not being used, they're out. And that creates a problem. Okay, when the stabilizers aren't using, or when the stabilizers are atrophied, meaning they're very, very weak, then something has to hold us together. And when the stabilizers aren't holding us together, and when the ligamentous tissue isn't holding us together, that puts all the onus on the movers. And at this point in time, the movers, not only do they have to move, but they have to stabilize as well. And as you can imagine, this is a little bit challenging for those movers. This is as if you are, as if you're taking a sprinter and you're saying, okay, I need you to go run 26 miles when they normally run the 100-meter dash. Or, if you ask me, who I'm a physical therapist, and you say, hey, Rin, the person at the front desk is not here. I need you to go and work the front desk. I mean, it's similar. We're in the same office. It's just like the stabilizers and the movers. They're in the same body. But you put me up front and have me start dealing with insurance companies, and the next thing I know, I'm going to be pulling my hair out and throwing things all over the place. And your movers are the same way. When you ask a mover, mover muscles, so the muscles like this one, like your erector spinae, which are the big, long muscles, or your pecs, or your abs, or your hip flexors, when you ask those muscles, hey, I need you to move me, but then I also need you to keep me stable, they just don't know how to do it. And that puts your body at risk for injury, for inflammation, and of course for pain. Okay, this is the perfect way to create pain in the system. It's the perfect way to create a strain or a sprain of a joint. So that is kind of that relationship, and what we need to do with our exercises and what we need to do with physical therapy is protect those joints. And the way that we protect those joints is by getting the stabilizers to turn on, getting these guys right here to start doing their job again. So the stabilizers can be stabilizers, movers can be movers, and there can be this nice, wonderful relationship throughout our musculoskeletal system. So before I move on into these specific exercises, does anyone have any questions about any questions at all about what we've talked about so far? The connective tissue, stabilizers, muscles, how connective tissue and tendons and ligaments and all that stuff goes together. Okay, good. It doesn't look like it, so hopefully everybody's hearing good and we're all on the same page. All right, so exercises to improve stability in the neck. All right. Here are a few different examples of things that you can do. My favorite is the girl who's balancing the ball on the wall with her head. But the few exercises are very standard and very straightforward. You've got your chin tucks, which is on this top left. You've got your anterior, so the front neck muscles here. And then these are all your general exercises. So this one, she's pushing back into her hand. Here she's pushing to the right, she's pushing to the left, and then forward. Now, the key thing with all of these exercises is that they need to be subtle. Okay, we just talked about how stabilizers only work at 20 to 25% of their max effort. This means that if you start pushing too hard through these exercises, you're going to turn on the wrong muscles. Okay, if you blow past what these stabilizers are capable of doing, you're going to start turning on much, much bigger muscles that, are a mover, but are kind of coming in to help out because the stabilizers can't do the job. So with this individual right here, I kind of pulled this picture because when you're doing this exercise, she's actually pushing too hard, okay? She doesn't look super happy, but she's also pushing too hard, and you can tell because her SCMs are popping out right here. And those guys, you shouldn't really be able to see them. Here you can do the same thing. You can see this muscle popping out. This muscle really shouldn't be popping out if she was pushing just a little bit, okay? So we really want to make sure that it's nice and gentle. Now, isometrics, we're going to talk about these a little bit, but this is a great opportunity to talk about isometric activation. And isometric activation is where you're activating the muscles, but you're not actually moving the joint, okay? So you'll notice in this picture, she's pushing her head as if she's turning her head to the left here, but she's not actually moving her head. Same place here. It's as if she's turning her head to the right, but she's not actually moving her head. So she's turning all these muscles on in her neck, but there's no movement. This is by far the safest way to start off with exercises, okay? You find a neutral position and then you just gently, gently activate those muscles. The general rule of thumb that I tell my clients is that if you feel like you're barely pushing, you're probably doing it right. If you feel like you're really not working that hard, you're probably doing it right. These are not exercises that are going to make you sweat. These are exercises that are going to slowly, gently turn muscles on. Less is more. Always less is more, especially when you're dealing with a joint that isn't quite sure of where it should be in space because of the excessive mobility. All right, and then to the next one, we have the shoulder, okay? And so again, quickly just going back to show you guys what that shoulder looks like. Oops, I went too far. All right, so this is the shoulder, all right, and we talked about that bony approximation, how there's really not much weight. It's like a golf ball on top of a tee, okay? So in this joint, the shoulders are going to be extremely, extremely important. And I went through probably the 4 most important joints, the ones that are often the most problematic. The neck, of course, is really important because it houses your spinal cord. And the more mobility that you have in your neck, the more angry that spinal cord is going to get. And the more angry that spinal cord is going to get, the more dysautonomia symptoms that you might have, the more fainting spells you might have, the more blurred vision, dizziness, all of those types of awkward and frustrating and very, very debilitating symptoms are going to come into play if you have too much mobility and you're putting that cervical spine at risk, or that your spinal cord at risk. And so that's why the neck is so important. The shoulder, just because it's so mobile, and it's really your connection to the world. We use our hands for everything. And so here you see him doing internal isometrics, external isometrics. He's pushing in, he's pushing out, he's pushing forward, she's pushing back, and then here you're just squeezing those shoulder blades together. Again, we're really looking at trying to get nice, gentle activation and turn that rotator cuff on so that we can now keep our shoulder in our joint. The stronger that these stabilizing muscles become, the better we are at knowing where our shoulder is in space. Okay, and we'll talk about that a little bit more later. Here's just some general exercises used to improve the stability of the core. All right, and these Theraballs are awesome. They're a ton of fun. They're great to bounce up and down on. It kind of creates a little bit of muscle activation through there. And then, yeah, you have your pelvic tilts, gentle hands and knees position in order to keep that core engaged, wall push-ups, and then bridges. All right, and then lastly, we have the hip stability. Okay, this was one of the other ones I was speaking about earlier. Your hips are kind of like the cornerstone of your body, okay? Everything rests either above it or below it. The hips are kind of like that connecting piece between your trunk and your legs that move you. And so it's really important that those hips stay nice and stable and nice and strong. So again, gentle pushes, not too crazy, but getting those glutes on, getting those adductors on, and getting your lumbar spine and your deep core turned on, and then also your clams for your abduction. Okay, so we went through the definition of connective tissue dysfunction. We went through hypermobility and what that means to your system. What does that mean as far as how does it translate into joint, and what can we do in order to stabilize those joints and overcome that hypermobility? But the next point is, what if you don't? What if you can't? What if you don't have the strength in order to really control that hypermobility? That, of course, is going to be something you guys are all very familiar with, and that is more of that pain point. When you have a lot of mobility and you put those joints at risk and you put those joints at injury, then you can have a lot of pain. Now, there are 3 different types of pain, okay? And we're going to briefly touch on each of them. The definitions of pain it's definitely grown and evolved over the last years, and we're starting to learn more and more about it. And the Ehlers-Danlos community is really part of that as far as helping us to better understand what all is involved with pain. So nociceptive pain is what we think about most commonly, okay? You have a broken arm, there's a physiological bone injury, it hurts. You cut your finger right at the crease with like a paper cut, it's the worst thing. There's a soft tissue injury, it causes pain. Dislocated kneecap, ligamentous tendon injury, you end up with pain, okay? This is a very straightforward type of presentation. It's much more acute, it makes sense, and the medical world understands this pretty well. So as far as physical therapists, what do we do with this nociceptive pain, okay? We aid in the healing process by helping to decrease swelling, to stabilize the joint, protect the joint. We do this with any type of bracing or taping or ice and different exercises. There's many things depending on what that injury is. We're going to address any soft tissue dysfunctions that may have occurred through soft tissue mobilization, putting that tissue in the most optimal position in order to heal. We're going to address any joint dysfunction by improving bony alignment in case some of the bones maybe have been jolted or they weren't moving properly. We're going to improve bony movement patterns. And then lastly, we're going to improve overall large movement patterns, okay? Really working on educating the body how to move again. So for example, if you injure your shoulder, the first thing we do is pull that shoulder into our bodies and hold it in close. I'm sure you've seen people who are in slings and that shoulder is just really tucked in on the inside. After that heals, you've got to get that movement back. You've got to be able to get that shoulder back onto your back. You've got to be able to reach up to the top shelf in order to get that bowl off. And that's where that neuromotor re-education is. Our bodies need to be retrained on how to make things move. Now, the second type of pain that we're going to talk about is neurogenic pain. This one's a little bit more confusing and a little bit newer into the world of research. So if you look at this blue line, this is your normal pain response, okay? And so there's some type of a stimulus, it doesn't really cause a problem, and then as that stimulus intensity increases, so at first it's your brother poking you with his finger, and then it's him poking you with scissors, and then it's him poking you with a knife, and at that point in time, this is where you find like, oh my gosh, this hurts. It's time to stop poking me. And this is when you end up with this pain response, and this is where it really you start to recognize that stimulus as painful. Now, when there is an injury, when there is what we call chronic pain, so pain that lasts more than 3 months, when there is something else in the system that has amped up that nervous system, then we end up with this line, the stimulus intensity line, shifting to the left, okay? And so now our body responds to things that typically would not have been noxious. So here, along this line, typically right along this point of stimulus intensity, this would just be, at the same level as, your younger brother poking you with his finger. But now, since your body is so heightened, there's so much of an awareness there, now that poking of your finger is sensed by your body as pain. And your body's like, whoa! And so the pain response that initially you had way over here has now shifted to the left, and now you have a pain response to something that before would not have been recognized as painful, okay? That's kind of what we talk about as far as neurogenic pain. It's more of a centrally mediated pain, something that is there and is now being recognized as pain simply because of the heightened alertness of that system. And it's a really important thing when you're talking about people who are fighting with Ehlers-Danlos, because now you've been dealing with pain, you've been suffering with these types of challenges, and your system is always at fight or flight mode. The system is always aware. It's always highly, highly turned on. And the idea is that we need the system to not be so responsive. So what causes neurogenic pain? Okay, and I'm not sure why rhinos speak to me, but they do apparently. But there's so many things that can cause your system to become more aware, to become hyperallergesic, okay? And so the things that cause that system to become hyperallergesic can be whatever's stressing you out in your life. Lack of sleep is huge. Depression and anxiety, pain and dysfunction, family and friends, not being able to do what you want to do, anything that is going to put your system on a high level of alert. Other things in this could be eating foods that you're not able to digest, or taking medications that your body can't process, or anything that is going to be, again, like a younger brother poking you, is going to continuously bump up that hyperallergesic effect and cause things that initially weren't really painful to become painful. And please understand that these stimuli, this is not a pain that is all in your head. This is a pain that is truly eliciting the neurological response of pain. This is real pain, and this is what you are truly feeling. It is just that the system is now recognizing something different as pain than it did, perhaps a year ago or 2 years ago. So what can you do about this? What can you do about the neurogenic pain? The things that I have found to be most helpful are things that are very similar to rocking a baby, okay? And you kind of go back and you think about newborn babies, and they're screaming and they're not happy, and you don't know what they need. Kind of often taking that baby and just gently rocking it back and forth, giving it a small movement, getting into a very comfortable position. And so you can see that a lot of these exercises, you're actually kind of pulling into yourself. Your knees are coming towards your trunk. Your shoulders are coming towards your trunk. It's this protective position where you're really protecting your inside, but at the same time, you're allowing your body to move, okay? Kind of coming in and rotating through that upper trunk, rotating through your lower trunk, doing your pelvic tilts. If you're sitting somewhere, just sitting and moving right to left and rotating while sitting. All of these gentle motions, again, are very similar to rocking a baby when it's very upset. And that's essentially what you're trying to do. You're trying to pull your body out of this heightened state and kind of reassure that everything will be okay. All right, and then the third type of pain that we're just going to briefly touch on is visceral pain, okay? This was a new thing to me. I had no idea until I got to PT school, other than the heart, that any viscera or organs could refer pain like this. But you'll just kind of see. It's a good picture to look at, but looking at where different things refer. So your stomach can refer pain right in the center, in between your shoulder blades, okay, which is quite interesting considering a lot of people have what's called periscapular pain. You can have pain in the left side of your neck because of the lung and diaphragm, the right side, the liver and gallbladder. So these are all things I'll let you guys just kind of look at on your own, but it is definitely something to be aware of, and that visceral pain and how that impacts your body as well. So we've made it quickly through this, and so you've got your connective tissue dysfunction, which leads to hypermobility, which leads to pain, and now we're just going to very briefly talk about impaired movement patterns. So this picture didn't come across not quite as awesome as I wanted it to, but looking at impaired movement patterns, basically what that means is you're moving incorrectly. Now, why are you moving incorrectly? Is it because of pain? Is it because of you're creating a compensation pattern? Could it be poor muscle activation? Could it also be poor proprioception? Now, proprioception is essentially body awareness. So the proprioception is essentially when you close your eyes and you bring your body to the right and you bring your body to the left. Proprioception is what allows you to know, okay, I'm moving to the right, I'm moving to the left. It's what allows you to recognize where you are in space without using your eyes. And this is something that is quite often impaired in people who have a lot of joint mobility. So just as this example, she's doing a jump test and she's jumping off of this box onto the ground, and here is where the problem is occurring. Those knees are collapsing in on each other, okay? And with that collapse, we are clearly putting a lot of strain on the inside of the knees, the outside of the knees, the outside of the ankles, the outside of the hips, and this is what I would consider an impaired movement pattern, all right? Same thing here. We're talking yoga, okay? It looks like she's doing cobra, but she's got some impaired movements here, even though it's a bit of a holding pattern, but you see that hyperextension at the elbows, and that's what we want to try and control. Same thing with something as simple as writing, that hyperextension through that finger while gripping that pen, trying to find another way to really relax and hold the pen and allow your fingers to move the right way. Now, the problem with impaired movement pattern is it just continues to increase your risk for injury, okay? And we really want to do everything we can back at the front of our little list. So really everything we can to increase stability, to fight that hypermobility, and to control the pain so that we don't end up creating impaired movement patterns, because that is going to end up making bigger injuries and bigger problems. All right, and then the last piece of this is really after you have those impaired movement patterns, if you're dealing with pain, then you're going to end up with decreased activity. Decreased activity can lead to decreased stamina, of course, impaired movement patterns, atrophy of muscles, which is where those muscles get weak, increased anxiety and depression. So remember those awesome rhinoceri, I'm not sure how to say that, and fear of movement is also another really big one that leads to decreased activity, and then decrease in functional ability. So the things that you used to be able to do, you can't do anymore, and that is stopping you from trying other new things. So this is a pathway that we find often. This is that dysfunctional pathway that we find often that leads to overall challenges. And so we're going to spend the rest of the time really talking about why exercise is so important. And I hope that this first part has kind of made it clear as to the impact that stabilization can have and the impact that movement can have. Does anyone have any questions before we kind of continue forward?
Hey, Kathryn, it's just Lauren here with EDS.
Yeah.
We are collecting the questions that attendees are sending in the question panel. They are not able to speak right now,
Okay.
but we are collecting those for after the presentation when you're ready for the Q&A session.
Perfect. Yes, I see that now. I just did not scroll down. All right, excellent. I will. Yeah, I think that'll probably be the best way to go. Instead, since we're kind of segmented now, is to hit those when we get to the very end. All right, thank you so much. All right, guys. So pulling back up this main screen that we kind of started with, and we've gone through this first segment, the managed movement dysfunction. Okay, now we're going to move on to the challenges with daily social and recreational activities and expand the importance of exercise just a little bit further. Now, I'm sure everyone who is fighting with Ehlers-Danlos is very aware of the impact that it has on all aspects of life: cognitive, sleep, psychosomatic, gastrointestinal, cardiac, and how much that can really play a part in your quality of life. Now, I know we all know that exercise is good for us. All of us know that. But it is really, really hard to believe it when it takes so much effort and can often be painful. And trying to find that balance between too much and not enough can also often be the trickiest part of integrating physical therapy and exercise into your day. But quickly, just to remind everyone, I want to make a point with each of these as to how the musculoskeletal system can really help out with these different larger visceral processes in the body, okay? So the first one is going to be your cardiac. Oftentimes cardiac issues include poor response to change in position, so that either orthostatic hypotension or POTS or getting lightheaded, dizzy, blurred vision, anything like that. With exercises, you can work to improve the blood flow. You can do specific exercises before you stand up or before you move. You can also retrain the response to postural changes. It's a slow, gradual process, but it's something that can definitely be done. Often there is poor cardiac strength and endurance. All right, and with this, we want to approach this with graded challenge to the cardiovascular system to improve strength and endurance. So if you haven't gone out and done much, if you haven't really tested that heart recently, you're not going to go out and go for a 30-minute run, but you are going to do nice, slow, graded exercises. All right, and then you have your poor venous return, okay, and this can, of course, lead to some of the postural change issues that we talked about earlier, but the use of compression garments, and I think there was actually a webinar about that earlier, and this helps to better maximize the function of the muscular component, okay. Gastrointestinal and musculoskeletal, okay? So heightened sympathetic and suppressed parasympathetic, which we really didn't talk too much about, but it's really just being at that very anxious, alert, aware state. It leads to poor sleep habits and high anxiety. And the poor sleep habits, that can lead to poor food digestion, because it's when we're sleeping and when we're in that parasympathetic state that we actually digest our food. And so if you're not digesting your food, then you're not going to get the proper nutrient absorption. This can lead to early morning nausea, difficulty with eating certain types of food, extreme reactions to food. One of the most common, of course, is going to be you're going to have your gluten, your dairy, and your sugars, which are also often very, very challenging to digest on a system that is not working at 100%. And then all of these things, not having the right nutrient absorption, not having enough sleep, being high anxiety, and having extreme reactions to your food is going to decrease muscle growth and healing time. All right, which can lead to sustained inflammation in a system. If you injure yourself, it's going to hurt worse and it's going to hurt longer. And a delayed response to exercise routine. One of the biggest challenges with really diving into an exercise routine is the fact that you don't really see immediate results. It can really take up to 6 months before you start to see major changes. And the gastrointestinal process and how much that impacts the amount of protein that you have in your system and the building blocks for muscle strengthening is a huge part of why that could take so long. Psychosomatic and musculoskeletal. This is all very, very straightforward in the sense of decreased activity level, decreased age, and appropriate interactions. Loss of control and disconnect from body all lead to anxiety and depression. But if you can increase that activity level, if you can return to age-appropriate interactions, if you can regain the control of your connection to your body, then you're really going to have an improvement in that anxiety and depression. the way that we work through this with physical therapy is, one, we give you rescue exercises. We put you back in control when you start to have that pain. We start in trying to integrate anti-stress activities, and this is, of course, different for everyone. For some people, it may be swimming. For some people, it may be hiking. For some people, it may be singing. Going out, cranking out the radio in the car and just, rocking out. It's different for every individual, but finding that activity that really helps to decrease your stress. And then, of course, relaxation exercises, all right? She's kind of laying on her back, working on some deep breathing. And then finding those trusting, collaborative relationships, the people that are going to be there and are going to help you to grow and help you to be stronger and help keep you on the right track is very important. And then lastly, you have cognitive function and musculoskeletal system. Oh, sorry, we have one more after that. But activity, movement, and just engagement really helps to improve blood flow. We know it helps improve endorphins. It puts you back in the control seat, which also gives us more of an elevated sense of purpose. And it makes us, again, puts us back in control. And it helps to decrease brain fog and confusion and difficulty with focus. And then lastly, sleep and musculoskeletal. Sleep is something that we all really wish we had more of, especially those who are dealing with Ehlers-Danlos. But the more that you get out and exercise, and the more that you move appropriately and exercise appropriately, you can relieve anxiety, which allows for quieter mind for sleep, fatigues the system, which allows for sleeping more easily, and can help reduce pain, which of course helps us to sleep a little bit more comfortably. Okay, I know these are just big picture global statements, but I just wanted to reiterate how the musculoskeletal system can really impact all these other components of life. All right, lastly, we're going to talk about restoring, maintaining, and promoting optimal function, wellness, and quality of life. And then the preventing and progression of functional limitations and disabilities. And we're going to do this by taking the big picture items that we talked about before and just kind of narrowing them down into a little bit more of a specific program that is focused on these two things. It's focusing on maintenance and focusing on progression. Okay? Depending on where you are with your, with your musculoskeletal system, you're either working to progress, to become better, to become stronger, or you're working to maintain. If you're doing well and you're moving and you've got those exercises down pat, then that's where you want to be. It's a lifelong challenge. It's a lifelong thing. You will never reach a point where you don't have to exercise anymore. For people with Ehlers-Danlos, exercise is like insulin for those who have diabetes. It is an everyday thing. It is part of their life, and exercise needs to be part of your life as well. 4 major blocks of your progression and your maintenance program are going to be to move. Closed chain exercises, which I'll talk about that in a second, rescue exercises, and integrative exercises. First, move. This is just a big overarching theme. Just move. Our bodies like to move. The more mobile we are, the more our bodies like to move. The happier our bodies are when we're moving. Sometimes it may not seem like that. Sometimes it may seem that all you want to do is curl up on the couch. But the more that you move, the better off you're going to be at keeping those muscles strong, and the more your body will thank you later. So pull exercises, recumbent bike, walking, these exercises that are going to be low impact on the joint but are going to make a really big difference. Key ideas: start slow and easy, okay? Don't go out and swim a mile. Come back in, starting a couple days a week, and really work on keeping everything under wraps and not going too fast. Monitor your heart rate. Know what your heart rate should be. Know what your heart rate max is and what your lower heart rate range is. Of course, with all of these things, make sure that you talk to your doctor, talk to your cardiologist, talk to whomever your clinician is, and let them know what your thoughts are so that they can get really a viable plan for you. And then, of course, train both endurance and at a variable heart rate. So don't just go at one speed. Go a little bit faster and then go a little bit slower, and then go a little bit faster and then go a little bit slower. And then one day do just endurance, just one speed. Our heart needs to be able to do both. It needs to be able to beat at a nice, steady beat, and then it needs to be able to pick up, sometimes especially around Halloween, and then it needs to be able to slow down so that we can sleep. So we want to train our heart to be variable. So closed kinetic chain exercises, this was that second building block of this program. Closed kinetic chain exercises are exercises where essentially the moving piece is on the ground, okay? So if you look here, this is open kinetic chain. This is not the best picture ever, but you're sitting in a chair and the foot is hanging down. There is no, this foot is not on anything. It's just kind of swinging in the air, okay? So it's like a little kid that's in a big chair and their feet are just kind of swinging. That is open kinetic chain, okay? The system is not closed. Here, this is closed kinetic chain, okay? So with closed kinetic chain, the feet are on the ground, all right? And then the body weight is coming on top of it. So that is what we want to do. The reason why we use closed kinetic chain is because it loads the joints more properly, more appropriately, and it also improves that proprioceptive input, which is what we had talked about earlier, that input that allows us to know where our joint is in space. Examples of closed kinetic chain, and again, this is very generic, but supine, which is laying on your back, side lying, laying on your side, doing exercises on your hands and knees, doing exercises leaning against the wall, exercises just on your knees, and what's called tall kneeling, so you're kneeling with your body up straight, and then balance exercises. You can be creative with this. You can kind of go and search online. I didn't put down anything specific as far as pictures because it's going to be different for everyone, but kind of going through and working in these different body positions in order to strengthen is going to be a great way to go. So, I did pictures. So here's a couple of examples for you guys. This is tall kneeling, okay? She's on her knees, she's up straight. She's just pushing this away from her chest. This is a closed chain exercise because she's got her knees on the ground and her legs aren't moving anywhere. Then you have a hands and knees exercise. Now here, this is technically closed chain, and then she lifts up, which makes it more open chain, but this is really where you want to go with that. And then balance exercises where she's standing in tandem in order to really challenge the one heel in front of your toe. And again, that's going to help to improve your balance, improve your proprioception, and really make you more stable on your feet. The third piece is going to be integrative exercises. So integrative exercises are exercises that use your upper body and your lower body, sometimes in the same direction, sometimes in opposite directions. It's kind of like that thing that you tried to do when you were younger where you're patting your head and rubbing your stomach. That is and still is very challenging for me to do, but it is using two different body parts to do two different things and trying to coordinate it. This is a brain challenge just as much as it is a body challenge, and it really helps to connect your motor cortex, which is what moves your body, with your planning cortex, which is the more of like the planning axis of the brain. So here you see cross body patterns where she's going from her top left to her bottom, or top right to her bottom left, okay? Combination arm movements and combination leg movements. And this is an example of her doing the same thing with both arms. Both arms she's coming out, and then she's bringing them together, okay? But you can also make them difficult by doing opposites. So here, this is actually quite challenging, I think, where you have one heel up and then the opposite toe, and then you switch. One heel, one toe, switch. One heel, one toe, switch. One heel, one toe. Play with it a little bit and see what you can come up with. All right, but those integrative exercises, they're helping to really, again, integrate your body. Make your body remember that your right shoulder is really connected to your left hip. It's helping your body remember that your 2 feet work simultaneously, and it's not just one foot moving independently of a second foot. We're trying to reconnect everything. And then lastly are your rescue exercises. These you guys have seen before, and I keep hitting on them, but they're really, really important. Having those exercises that will help you to control your pain, to get you out of that spiral and to kind of stop things from spinning. So just as the closing, just kind of pull all of this together, I want to go and talk through some general guidelines for exercise, some general rules. The first is you've got to make exercise a priority. Okay, like I said, exercise for clients with Ehlers-Danlos is like insulin for people with diabetes. You've got to do it every day. If not every day, kind of what I wrote out here, exercise 5 days a week. Okay, 5 days a week is going to be your minimum. Is really what your body needs. Unfortunately, the time it takes for your body to start to forget, to start to atrophy, is very, very minimal. We're talking like a day and a half to 2 days before those muscles start to atrophy and you start to go backwards, which is why exercising 5 days a week is very important, and being consistent. I often suggest with my clients that exercising 5 days a week, but never take off more than 1 day at a time. So if you're going to exercise, don't do it. If you're only doing it 5 days a week, don't go Monday through Friday and then take off Saturday and Sunday. You know, exercise Monday, Tuesday, Wednesday, take off Thursday, exercise Friday, Saturday, and then take off Sunday. All right, it'll be easier for your body to get back into the groove if you take off only 1 day at a time as opposed to 2. Definitely progress your exercises gradually. Okay, you've got to give your body time. The body, when you're fighting with Ehlers-Danlos, it's really hard to find a balance and to maintain a balance, and that is a part of the musculoskeletal system as well. And so you've got to add something and then let your body catch up. Then you add something and you let your body catch up. It's a lot of small steps, but being consistent with it, it's going to get you where you need to go. Find a partner to exercise with to help get you there on the tough days. There are definitely days where you just don't feel like you have it in you, but it's still really important to exercise when you're tired, exercise when you have minimal to moderate pain, and do yourself a favor. Keep a log of your regimen and your symptom pattern, and that'll be just some evidence for you so that, you know, when you've been doing this for 3 months and you're like, oh my gosh, nothing has changed, you look back to day 1 and you realize, okay, hang on a second. Before I could only walk 1 length of the pool. Now I can walk 5 lengths of the pool. Okay, this is a very big difference. And so give yourself that evidence to look back at and recognize and, you know, pat yourself on the back for all the hard work that you're doing. Treatment don'ts. This is important. Things that you should not do and things you should stay away from. Take off more than 1 day at a time from exercising. That was what I was just talking about. Open chain exercises. So those open chain exercises are like those big exercises where your arms are way out and you are not really kind of connected to the ground, because there's those times where you run the risk of dislocating or subluxing different parts of the body because you don't have that proprioceptive contact. So big open chain exercises. Don't progress your exercise routine too quickly. Don't get involved with large plyometric exercises. So CrossFit is a lot of large plyometric exercises. It is not going to be the best option. So jumping onto boxes and bigger movements like that, they're just a little too intense for what we're looking for. And this is going to be horrible for some people, but don't stretch, okay? Gentle foam rolling using like this stick, that's good. But stretching is really not going to be ideal because, as I mentioned before, when you stretch, it's not the muscle tissue that's actually stretching. It's the tendon, okay? So thinking back to the tendon being the rubber band and the muscle tissue being the coil, when you go to stretch, it's that rubber band that's going to stretch, and you're not really doing yourself a favor. It will feel good. It'll feel good for like 15 to 20 minutes. And then after that, it's going to go right back to, or maybe even worse than what it was before. So stretching is not great, but using a foam roller, using a stick, kind of having something to gently work those muscles out is a good way to go. And I emphasize gently. And then the last is going to be, don't push too fast and too hard on a good day. We all have those days where our endorphins are running, and you're feeling great, and you feel like you could just, conquer the world. Still be aware of where you are, okay? Those days can be the days where you just feel amazing and you just push through, and then the next thing you know, you're back down and out on the other side of that hill, for the next week. So be cognizant and be smart about how you exercise and sticking to a regimen that you've created. All right, and then what to expect as you begin, okay? As you begin, and we've hit on some of this already, it's going to be a slow progression, slow progression of impact on the symptoms and muscle growth, okay? We're talking, like I said here, 6 months until you really see a significant change. So really setting up small goals for yourself is going to be important, and be aware of how that process is going to go and the amount of effort that it's going to take to get you where you want to be. And also, of course, you're going to need to expect symptom provocation with the addition of new exercises. It comes with the territory. When that body has not been doing much and you start getting that movement again, you start challenging it, it's going to talk to you a little bit, and it's going to be a little bit angry. Be okay with it, recognize it, go through your rescue exercises, get it to calm down, and then go again. All right? It's symptom provocation, the general rule of thumb, and again, very general, is 4 or 5 out of 10 as far as pain goes. You don't want to go into extreme pain. You don't want to send yourself up into a flare, but you do need to push it just a little bit so that you can move beyond it. You've got to challenge yourself just enough. All right, and then the last piece that I just want to hit on is that exercise really is a form of medicine. And when you're dealing with GI issues and cardiac issues and all these other things that kind of come along often with Ehlers-Danlos, exercise is an insanely safe form of medicine. It does a phenomenal job of helping us to control everything else. It helps keep your body in what's called homeostasis. It helps us to find that balance, and it really works to create the best possible environment in which your body can thrive, muscularly, cardiovascularly, gastrointestinally, psychosomatically, and cognitively. All of these things kind of come together, and really getting that stability in your joints can literally and figuratively be the glue that helps to bring some control back into your life and into your regimen. And then, of course, as I mentioned in the beginning, individualized treatment is really important. Okay, everyone here, everyone who's listening to this webinar is an individual, and everyone presents differently. There are patterns, yes, but every single one of my clients that I work with based off of their personal impairments and how they respond to one exercise versus the other. So I would take this information, use it as a base, use it as a guideline, but it is not the full definition of what you need and what is going to work specifically for you. Take this information, find someone who can kind of help to develop a individual program specifically for you, and it is going to make a very, very big difference.